Okay, thank you very much for inviting me, Rafid, and thank you very much also for an excellent anatomy presentation, because that has made it much easier for me to then talk about the imaging. And initially I thought I had about an hour, so I've decimated my talk, and I'm literally going to focus on the degenerative changes in the cervical and lumbar spine. So all these of infection and other interesting things I've sort of cut out. So I won't even talk about anatomy because it's been beautifully done before. Just to show you that the MRIs and CTs just rather elegantly show the anatomy. So if you look here at your main anatomical specimen, you'll find that the MRI can show you really in quite good detail the structures of the spine. So you can see the spinal cord up there, you can see the white, this is a T2 scan showing you the spinal fluid, which is white on a T2. Fat is also white on a T2. And you can see that the discs, when they're nice and hydrated, they're white and plump. And as you get older and as you get more wear and tear, they become more desiccated. And one of the key areas that we as neuroradiologists look at is the intervertebral foramen, because this is sort of the keyhole to lumbar degenerative disease. And you'll see when we talk about discs and what happens, this is where you get your nerve roots, and so this is the important area for correlating degeneration with clinical presentation. So this is a nice normal lumbar spine. If we were to scan everybody in the room, even the youngest members, we'd find quite a lot of abnormalities on imaging that really had no relevance. So if you do a study on 20-year-olds, you'll find lots of them have imaging abnormalities that have no correlation with symptoms. When you get to my age, I've probably got a lot more, but it's just one of the things to bear in mind, that you don't treat a scan, you treat the patient. So going through the spondylotic diseases, as you saw with the elegant anatomy slide, the imaging shows you various stages of degeneration. I don't bother with grading, I just use terms mild, moderate, severe, and all of us in this room will have some degeneration, particularly if you've been active, particularly if you're older. You will have disease. That doesn't necessarily, you'll have degeneration. It's not necessarily pathological. When we look at discs, you have a normal, the so-called normal disc. Again, that's not necessarily normal because we all have bulges and things that I would consider to be part of normality. But when a disc does bulge, it bulges out in a broad spectrum. And it's usually very diffuse, but it can be asymmetric. And I regard disc bulges pretty much as normality. When we get to the group of disc herniations, there's a huge swathe of nomenclature that can be quite confusing. So people talk about prolapses, herniations, extrusions, and it can be quite confusing. And lots of people use different terms. And depending on where you trained, I trained at Queen Square, we had a particular way of labeling things. Then the Americans had their own way and they sort of took over. So you'll find the nomenclature changes completely. But a protrusion, I'm going to use terms that the North American Society uses just for homogeneity, but a protrusion is when you get disc going through a ruptured annulus, has a broad base, and it comes into the spinal canal and compresses. So you see this broad base over here, and it comes down and compresses a nerve. When you talk about extrusion, and again, it's not a term, it's not a condition that I considered to be that match these pictures. But an extrusion is when the disc herniates right out and goes up and goes into your canal and moves up or down. And usually it means that this dimension here is bigger than that dimension. In my experience, most extrusions are broad-based, and they are often migratory. And it doesn't really make much difference whether you talk about an extrusion or a protrusion, it's just degree. So I see a lot of migratory discs, particularly in the field that Rafid and I work, where patients have profound symptoms. So they're coming into hospital and they're being investigated urgently, usually in the middle of the night. So a migration can go up or down. The migratory discs can break off, and then we call them a sequestration. These types of discs, they're usually large. They usually cause significant neural compression. And when you get a disc herniation that's coming out into the neural foramen, you can see that you're going to affect your nerve root. So this is the North American nomenclature. So when I trained, we talked about midline, and we thoroughly disapproved of using central, because central should actually be, if you look at a sagittal plane, it should be where you get a Schmall's node. So it hurts me to say central, but I am beginning to use it. Hated the term paracentral. I called it posterolateral. And we were very strict on our nomenclature, but you see it's all changed. So we now use subarticular for the posterolateral, which is here. And then you get the far lateral or the intraforaminal discs. These are really important. They're often missed on scans because they can be quite subtle, but they cause compression of the nerve root. And then the extraforaminal zone, again, these can be quite subtle, and it's important to look carefully for them. It's very helpful for us as radiologists to have a good referrer who can examine the patient properly and know the neurology. So if Rafid sends me a scan and he says there's a L4 neurology, I'm going to search really hard, because a neurosurgical assessment of a particular radiculopathy will guide us, and we will really look for it. And even if it looks normal, we'll keep looking for it because we know there's probably something there. So this is just showing you where these discs occur and how they affect the nerve roots. So if we look at A, so we've got this is L3 and that's L4, and you've got a subarticular disc. It's going to affect L4. If you have an intraforaminal disc where you've got D, it's at L2-3, it's coming laterally, so you're going to get L2. And so you can see, just by the position of the discs, it's important to see which nerve root is coming out. So when we talk about, say, if we take the L4-5 level, you'll find neuroradiologists will talk about the foramen because of the nerve that goes through it. So I won't say the L4-5 foramen, I will say the L5 foramen, or I'll say the L4 foramen. I won't just use levels, I'll talk about the specific nerve root. So the central canal protrusion, these are discs that are usually broad-based, and these are the types of discs that can cause cauda equina compression. And these may be the cases that present to us at 4 in the morning with a clinical diagnosis of suspected cauda equina syndrome. The importance of this is that if this disc enlarges, it's going to come over here and compress the theca. It's going to efface the CSF, so we lose that nice white signal, and then we can then say to the surgeons, there is cauda equina compression. We don't use the word syndrome because that's a clinical diagnosis. We talk about the imaging aspects of the cauda equina roots and whether or not they're compromised. So here is a case who presented with Catriona syndrome. You can see that there's a large disc extrusion. It's broad-based, but it's very long here. It's causing marked compression of the theca. You can see there's a little bit of CSF signal remaining, but this patient had Catriona syndrome and they went on to have emergency surgery. You'll notice in this case, the bladder is not distended. It's very important for us to look at the bladder because it just helps with the surgeons and their timing and also prognosis of recovery. This is another case of Catriona syndrome presentation. We do a scan. You can see that here you've got complete obliteration of CSF. You've got very severe spinal stenosis. What's also important in this patient is something we see very commonly, and that is that some people constitutionally have a narrow canal. And that is because the pedicles are just genetically a little bit shorter, and along with that you have quite a lot of epidural fat behind. So the canal is intrinsically a little bit narrow, and then when you get a big disc, patients are more vulnerable. When we do the axial view, you can see it can be sometimes quite difficult to tell where the disc is, but it's a very edematous acute disc, and so it's almost the same colour as CSF and fat. But you can see that this theca is markedly compressed, lost CSF signal, and they need urgent surgery. So this is someone who presents with right S1 symptoms, and I'm just showing you a large extrusion coming in the subarticular zone, and you can see very marked compression of the nerve root on the right as it comes out of the dura. There's also compression of the theca, but as you can see, there's quite a lot of CSF signal. Now you may have spotted that you can see that the surgeons have been hacking away with knives, and you can see a little bit of fluid. You always see little bits of fluid after surgery. You can see also here that there was an epidural collection. So this patient actually presented after surgery with acute symptoms. Surprisingly not Catriona syndrome because there was quite a lot of compression, but of a right-sided radiculopathy. So we always look after surgery for recurrent disc and hematoma, and in this case there were both. Now looking at the migratory discs, you can see here that this is a disc that's migrating upwards, but what you can also see is that there's a fragment of disc, and that is of different signal from the native disc, and that's a sequestered fragment. The importance of a sequestered fragment is they can move up or down, and they tend to, it's very, very common with any migratory or sequestered disc to have significant neurology. And you can see here again, disc and disc here. Here's another migratory disc coming up behind the vertebral body. They're often superiorly migratory, and it's funny, you think gravity would make them go down, but we often see superiorly migratory discs. The migratory discs that go up, you're always looking at the nerve root above the level. So you're looking at the L3 nerve root will be compressed in that case. Foraminal stenosis, when we're talking general wear and tear and we're talking about spinal and foraminal stenosis, there is a grading system, and the grade 1 is when you've effaced the CSF and fat around the nerve root in one plane only. Grade 2 is when you've effaced it in all planes, and grade 3 when the nerve root's actually compressed. And again, the correlation between foraminal stenosis and clinical is often quite poor. And we often, in a very degenerative spine, you'll usually see pretty severe L5 foraminal stenosis. Now, here's another term that again makes me feel a bit queasy, is the term lateral recess. Again, my training was quite strict, and we weren't allowed to use the term lateral recess because, in fact, there is no recess in the spine, because a recess is a blind ending channel, and this is a channel, so it's not actually a recess. So I struggle to use the term, but it's the lateral part of the spine, of the spinal canal as it goes out towards the foramen. And that's an area where the nerve root gets pinched. And so you can see here, you get nice wide open space. Here it gets narrower and more narrow and more narrow. So you always have to look laterally in the spinal canal. So you can get some patients who on a sagittal view have a nice capacious spine, but when you look axially, you see that laterally they're quite stenotic. So it's always important to look at both aspects. And these are some pictures. I think what's important is you often, what I find is when you look at different radiologists, whether you're a general radiologist, a musculoskeletal radiologist, or a neuroradiologist, you will find that some people overcall stenosis, and we, as neuroradiologists, I think we tend to be more parsimonious. We prefer not to overcall because a lot of people naturally have quite small canals, or in a certain age group you know what is normal. So I think it's important to know your local radiologist or neuroradiologist, because there's quite a variety. So I often see cases that are called severe stenosis, and I would think only mild or moderate. So this is just showing you some stenosis. You can see on this picture here, you've got degenerate facet joints, you've got buccal ligaments, you've got synovial overgrowth, and you've got some effusions. And you see that canal, I'd say, is mild narrowing, but you can see the lateral recesses are narrowed, and you're probably pinching your nerve roots. This is just showing a more marked version of the above. You've got bigger ligaments, you've got slightly more degenerate facet joints, and you're beginning to get synovial cysts. And then here you've got a soccing great synovial cyst, in fact on both sides synovial overgrowth, and you've got a very narrow canal. So it's just the various things that can contribute to spinal stenosis, and then from the front you have disc coming backwards. So in all of these cases you're going to get nerve root compression. And you can see here you've lost CSF signal. One of the things that I find helpful to look about, to give you an idea of the significance of stenosis, when you get a very severe stenosis, the nerve roots above get all wiggly, and we call that redundancy of the nerve roots. And it's a feature that I find quite helpful, and when I see it, I tend to say, I describe it, and I say, as an indicator of the severity of stenosis. So it's something I see quite a lot, and it's particularly, you see it when it's chronic. Okay, so this patient comes in with left L5 symptoms, and the clinical question is there a disc prolapse? And here you don't have a disc prolapse, but you have a large edematous lesion here, and if that's a synovial cyst. So sometimes on axial imaging it can be difficult to tell whether this is coming from here or it's coming from here, but this is just a very common presentation when you see this related to your facet joint synovial cysts. So we see these quite commonly, and they often recur after drainage. Now, a difficult area of imaging for neurosurgeons and neuroradiologists is the postoperative spine, because the surgeons will go in and they'll do a discectomy, and the patient will get much better. But sometimes, either very shortly after surgery or at a subacute phase, they come back with recurrent symptoms. And then we often image, we're trying to work out, is this post-operative change, or is it recurrent disc, or is it hematoma, etc. So these are the things we're looking for. Now, in the very early phase, at the operative site, no matter how delicately and with precision the surgeon's been, the scan will actually often look a bit alarming. That's very, very common. No matter whether it's a tiny fenestration and it's been a very targeted approach, the initial scan within 6 hours can look bad, a bit like pituitary surgery. It can look really bad, but it isn't bad at all. It's just the body reacting. And it's important not to overcall. Now, what we see in the acute phase is you get edematous tissue at the site of the discectomy and around the side of the theca. And what you've got to work out, is that scar or is that recurrent disc? And the way to do it is to say we give contrast, and what happens is with contrast, if it's scar, it tends to enhance uniformly through the area. If it's disc, it tends to enhance peripherally. But sometimes, we'll sit together, neurosurgeons and neuroradiologists, looking at them and saying, not quite sure. So, things aren't an exact science, but generally, peripheral enhancement means recurrent disc. So you can see, I slightly wish I had a pointer here, you can see where that arrowhead is. There's a little, it's surrounded by enhancing scar. That's before contrast, that's after contrast, and that's got a little rim of enhancement around it. So that's a little recurrent disc fragment, and it's touching the nerve root. And what you also see, patients who have recurrent symptoms after surgery often have enhancement of the nerve root. So you get a little bit of enhancement of the nerve root and more enhancement here. Now this is this little recurrent disc fragment, but even when you don't have a recurrent disc fragment, if you have an enhancing nerve root, which is a little bit edematous and swollen after surgery, that can present as a neuropathy without any compression. So it's important to look for both factors. This is showing post-operative scar. So here we have, this is before contrast, very difficult to tell what's going on because you just see lots of stuff coming behind the disc. You couldn't tell what that is. When you give contrast, in this case, all of that enhances. This is the nerve root here that's swollen, and it's very common after a previous severe compression for the nerve root to be damaged, and so the nerve root is edematous, a bit swollen, and enhances. So this is scar tissue. We don't worry about the scar tissue because that will settle, but the patient has symptoms because this nerve root is damaged and just a bit delicate at the moment. And usually these patients will settle. So it's reassuring to get a scan like that, and then we'll do another follow-up scan, and usually these ones will resolve. This is a patient who did badly after surgery, and there's a large recurrent disc extrusion. It's edematous, it's a little bit of peripheral enhancement, and you've got marked compression of the nerve root and marked enhancement of the nerve root. So the surgeons will go in on that one. Now, just to show that sometimes patients will come to our MDTs. They've been seen in a district general hospital, that they see something and they think, is this a disc, is this a tumour? So this was referred to our MDT, this is quite a while ago, and the question was, is this a tumour? And you can see here, there's a soft tissue mass behind the vertebral body, and it comes laterally and fills the foramen. And it was thought to be a schwannoma, or neurofibroma schwannoma. And so we looked at it and we thought, no, we think this is a disc. Because usually when patients get referred with neurofibromas, they're about 95% they're discs. But you can see it's broad-based. It follows the tract of the foramen, and you can see it was very reasonable to think of this as a schwannoma. So we brought the patient back to give contrast, and you can see there's this peripheral enhancement. And this turned out to be a disc. Now, sometimes the schwannomas can be necrotic, So sometimes it's difficult to tell between the two, but it's just a common thing that we get in our MDTs. Just a few words about facet joint arthropathy. One of the features on imaging is we see so much wear and tear, and so you see a lot of degeneration in discs in symptomatic patients. But one of the features that I think is helpful clinically is when we see what I call active facet joint arthropathy. So you've got severe degeneration, but it's showing edema. And there's a correlation when you see edematous facet joint changes on imaging and symptoms. So it's important in back pain. And of course, we alluded to it, but spondylolysis and spondylolisthesis are important features to pick up on imaging because of correlation with symptoms. And just one final thing to say that, just following on from the first talk, one of the things that we do notice on imaging that's important for the surgeons and physiotherapists and chiropractors to know is if there's a transitional spine. So when the levels are slightly different from the standard 5 lumbar vertebrae or 12 thoracic vertebrae. Sometimes we only have 11 ribs, sometimes we have 13 ribs, and so often you get a transitional lumbosacral junction. It can then be difficult to label the levels, so on imaging, if we see that, we usually make a comment that there is a transitional level, and for the surgeons just to be very aware to check levels carefully when they operate. So that is the covering the lumbar spine. Just a few words about the cervical region, because it looks different on imaging. And the reason it's important in the cervical region is to understand the uncovertebral joint, because this is the joint that is most prone to degeneration. So it's lateral, and it's the reason why you get foraminal stenosis. So this is the keyhole we talked about, and you can see these are uncovertebral osteophytes that are narrowing the foramina. So when I talk about cervical foraminal stenosis, I use the term uncovertebral foraminal stenosis. So you can see here, this is these large lateral osteophytes coming from the uncovertebral joints, causing severe foraminal stenosis. The next important point about cervical spondylosis is that you generally, apart from young patients who you often get a disc prolapse, usually in the degenerative spectrum, you get a disc osteophyte complex or disc osteophyte bar, osteodiscal bar. These are the terms we use, and you can see that there's this chronic, partially calcified, partially ossified component coming back from the disc, which is usually a combination of disc and calcification or bone. And that's important because it's usually not soft. And apart from the cases when you get generally a very young person who presents with very acute symptoms, and we see an edematous disc as we do in the lumbar spine, most of them are combinations of the two. And just a few terms about post-surgery. So the most common surgery that we see in the cervical region is an anterior cervical decompression and fusion, and there are different techniques that Rafid and his colleagues will use, but the common things, you get a disc spacer, or you get a disc replacement, or you get different types of disc placements. They all look a little bit different on imaging, but the general approach is the same. What you often see on imaging is some artifact. So when you do a sagittal image, it looks as though that's protruding into the canal, but that's often just artifact. In this case, you can see that the canal is actually all right, but it looks as though you're compressing the spinal cord. So just to be aware, and we as imagers have to be very careful of differentiating artifact from true compression. This is a case showing a posterior hematoma compressing the spinal cord. Here's another hematoma. Now, an important point to note is here you can see a large compressive hematoma. This is an indication to go straight back in and decompress. But one of the features, if you forget all of this here and here, when you have a disc spacer from surgery, you always get some fluid oozing behind the spacer. That's normal. And I've seen a few medico-legal cases where they've talked about hematomas, and actually that's just the normal appearance after surgery. And that's obviously, you know, someone has criticized a surgeon to say that there's, you know, it hasn't been placed correctly. In fact, it has, and it's just obviously a radiologist who doesn't deal with post-operative cases. One of the distressing conditions after surgery, the surgeon does a great job. They've put in the spaces, they've decompressed the spine, but the patient wakes up with profound myelopathy. And every now and then we get what we call the white cord syndrome. So this is before surgery. You can see a very degenerative spine. The spinal cord is compressed and you've got myelomalacia. So myelomalacia is the term that you've got mature damage to the cord substance, and they present with myelopathy. So the surgeons have done a very nice decompression. You can see the spinal canal dimensions are capacious. There's no spinal hematoma, so all the dimensions are good, but the spinal cord has got lots of edema and swelling. And the thought process is that this is probably microvascular ischemia, probably partly venous ischemia, because of a decompression reperfusion syndrome. But it's quite distressing to see, but it's no fault, it's just one of these things that happens unusually after an adequate decompression. The take-home points are, it's really important to, first of all, to know your anatomy, as in the first talk. Secondly, to correlate your anatomy with neurology. Don't overcall normal wear and tear. Imaging lesions don't necessarily correlate with symptoms and signs. So we may do a scan and we may see severe stenosis at L3-4, but in fact the patient's presenting with S1 radiculopathy, and so it's important for the surgeons to look at the scan but fit it in with the symptoms. And if a patient has myelopathy or cord recliner syndrome, these patients need to come straight to A&E. They need an urgent scan that night, if it's at night, or that day, because surgery needs to be performed rapidly and there's no time to hang about. Any questions?